we've lost half the audience already. Okay, well, hopefully you can all hear me remotely and see the screen okay. So had a fairly wide remit as to what to talk about, but it was suggested that perhaps something on abdominal imaging would be helpful. So a few slides on that to go through. Then I've got some other material on just regular x-rays and fractures and what have you, and things to look out for. So we'll crack on without any further ado. And the first thing I want to say is that plain film abdominal imaging has limited use in the evaluation of acute abdominal pain. It has extremely low diagnostic yield. You often get misleading and incidental findings. Sorry. Okay. Right. Unfortunately, that's going to ruin some of the animation, but we'll just have to do that. Okay. The lack of impact on management. There is an exception in cases of bowel obstruction or perforation, although I will say that the abdominal film is mostly useless for perforation as well. So there's a study, Brewer et al. In 1976, which looked at 1,000 patients with abdominal pain. 38% had radiography, and the clinical diagnosis was altered by the X-ray findings in precisely 0%. So back in 1976, we knew it was pretty useless. Yet here we are, 50 years later, still insisting on doing them. The latest study of obstruction, patients with obstruction, was actually all you're really doing is delaying the CT scan. However, I'm aware that some of our surgeons are extremely keen on having a picture, no matter how useless. Okay, and just the usual caveats about what the impact of inappropriate referrals. You know, it's an unnecessary radiation dose for the patient. Doses are low, and that really isn't a massive concern. If you've got a young, particularly female patient, then we're obviously rather more concerned. But by and large, the doses are pretty low, and that isn't. But it does delay getting the patient to the right place, getting the appropriate examination, and therefore delays their diagnosis. And it delays other patients because we're dealing with a finite resource, and while we're doing the pointless stuff, we can't be doing the stuff that's really needed. So I'll have a look at the normal abdomen. So you can't tell a great deal. We're looking, as usual, at differences in grey. So stuff that's black is going to have gas in it. Stuff that's grey is going to be soft tissue, and the white stuff is bone or stone. But there's much to add to that, really. It's just those are the things you can see. And if you look in any textbook of abdominal anatomy, that's what you'll see. So we do need to have the patient appropriately prepared. So we need the clothing removed because artifacts do bother us. Females of childbearing age, now we say 10 to 55. If you've got a 56-year-old and they're still capable of childbearing, that is included. It's not an absolute cut-off. We do need to establish their pregnancy status to avoid the risk of irradiating an unsuspected pregnancy. Just need to remember that the BCG is not reliable when the lady is within her normal period. Okay, so 28 days, whatever that is. And if we're worried about perforation, then the patient needs to have been sat erect for at least 15 minutes to allow the gas to rise up and become visible and that would be on the chest X-ray. So here's an example of some artifacts. We've got, not quite sure what the angled metal structure in the top is, some construction on the trolley, I think, but we've got a zip, we've got change in the pocket. It's very unsatisfactory when you can't see the whole image. You do run the risk of missing important pathology. Stop moving. This one, now, there's two choices here. Either the patient had a gunshot wound, or they're wearing items of clothing with a lot of sequins on. And actually, just from this, we can see that there is a lot of clothing artifact. We've got these little linear streaks which indicate folds of cloth. So I don't know. I mean, I would hope that you would be able to tell me that the patient had been shot. So that's one of the things. So well, and we do come across other artifacts. Well, this was we were just told that the patient had abdo pain. We hadn't been told that they'd inserted an aerosol can through one of the orifices available. But that is gas within the plastic cap, which is the only hint that it's there. So, perforation. There's a lot of signs that you can see, and I'll come across them. There's a lot of signs that you can see on abdominal X-rays, which, okay, they exist and they're named, but they're not particularly useful. So, free air, which is Wriggler's sign, you only get it in about 40% of abdominal images where there is perforation. So the erect chest X-ray has a much higher yield, and as I said before, it needs to be erect for at least 15 minutes. But here's Wriggler's sign, which is you can see both sides of the bowel wall. Okay, and hopefully that's clear from the arrows there. Also wonder about this. This is a more typical presentation of query perforation. We can't see it. It's just not visible on there. However, this is the erect chest X-ray that goes with that patient. And you can see very clearly quite a lot of gas in the diaphragm. Unfortunately, on abdominal imaging, as I say, 60% of the time you just won't see it. So it does call into question why you bother. Apart from the enthusiasm of the surgeons, of course. A nuclear course, don't get distracted by the normal gastric bubble. Okay, in the classic position, also considerably thicker soft tissue between the bubble and the lung, because you've got the diaphragm and the gastric mucosa between, whereas on pre-gas you've only got the diaphragm printing it. Okay, so obstruction, just bear in mind the normal caliber is 2.5 to 3 centimeters in the small bowel. Large bowel is 6 centimeters, 9 centimeters at cecum, and then the simple rule of 369. Try and help you remember those dimensions. Two interesting ones, which I probably will allow an abdominal X-ray, is volvulus, because that's fairly classic and easily diagnosed off the plain film. If you see any sort of obstruction on a plain film, you're normally going to the CT scanner almost straight away. So if that is your genuine concern, you're better off going to CT without messing about. Okay, so we have classic small bowel obstruction. So the alveolar conventives traverse the entire width. It's clearly more than, well, it would be clearly more than 3 centimeters on a VAR screens. You okay there? Yeah. And interesting though, we still have gas in the rectum, so it's not a complete obstruction because gas is still getting through. But again, no clues are given about the location of the obstruction, what's causing it. So you're going to go to CT. So you know, why delay the inevitable? Here's a more classic large bowel obstruction with the transverse and ascending colon extremely dilated. Appropriately, yeah. Sigmoid volvulus, Marge Simpson's hair. So extremely dilated. You have dilated large bowel backing up and proximal to it. but large, central, usually vertical in orientation. Okay, and then the classic for cecal volvulus is the so-called coffee bean sign. But that's fairly straightforward. That's the Y. And then there's other sort of obstruction-like things, which gallstone ileus is one of the most common we'll come across. There, you just get a localized loop of small valve with dilation. Okay, any questions on that?
The vertical lines, what frustration?
Yeah, valvulary conventis.
Okay.
Technical valve. Large valve, you don't tend to get there because the large valve plates, you don't get any soft tissue crossing the bands. Was that someone at home? Sorry, I didn't catch that.
In the previous X-ray where we see gallstone ileus, is there any evidence of air cholangiogram or any telltale sign of that?
Not on this image, I don't think, although you can get it, obviously, and it is one of the things to look out for. I think I've got some slides later on that will demonstrate it.
Okay.
Okay?
Yeah, thank you.
So another gallstone ileus, just a very localized loop of valve. So irritable bowel disease. So we've got Crohn's, ulcerative colitis, toxic megacolon. That's our chief concern there. Let's come down a bit. One of the classic signs here in the transverse colon is so-called thumbprinting, where the bowel wall edema just makes the, if you can see that on the benefit of people in the room. Yeah, I can use my arrow there to those areas there. So that's bowel wall edema, which just shows that thickening. So that's a sure sign of inflammatory bowel disease. And this was an infective colitis, although hard to diagnose just from the image, to be honest, and it's more to do with the complete clinical picture. This one we normally show you with a blown up section, but because we're just going through the slides rather than the presentation. This is intramural gas, so this is the next stage. So you get this streaky appearance within the bowel wall itself, which is, you know, the precursor to perforation. Hopefully the surgeons are involved at this stage. And here's sort of full-blown megacolon with the classic lead pipe appearance of the descending colon, as you lose all the texture in the bowel. And an ischemic colitis, where again you've got the thumbprinting in the transverse colon. Again, the definitive diagnosis just isn't possible from the plain film. It comes from other things. Okay, other findings. So there's lots of other pathologies that you can see on an abdomen. So I'll just run through them, but you wouldn't do the abdomen X-ray to diagnose these conditions. Okay. We start off with ascites. What we're seeing is a largely featureless bowel, everything pushed out to the side. Okay, just because it could be a mass, it could be ascites again. Not something that we would attempt to diagnose from the film. Staghorn calculus in the left kidney. Okay, AAA, just seeing the bulge in the calcified wall of the aorta there. Clearly distended, but again, it's not a diagnostic image. It's an incidental finding, really. Very large spleen. We can see there's something occupying the whole of the left side of the abdomen there. Ultrasound is going to be much more useful to you. So interesting little calcifications you come across. This is a splenic artery aneurysm. nicely rounded, classically on the left, so you don't confuse it with anything going on in the gallbladder. My personal favourite, because it's just a very pleasing, wiggly, three-dimensional tube, is just splenic artery calcification. It's one of the things that makes my day when I see it, because it's more interesting than most of it. Most of the stuff. So huge soft tissue mass. Again, we've just got something that's obliterating the centre of the abdomen, pushing everything out to the side. That turned out to be a liposarcoma. We've got gallstones. It's only around about 20 to 30% of gallstones calcified. But we can see them sitting there quite nicely. There's also a PUJ stone. Okay. Porcelain gallbladder. Again, the only purpose of doing this X-ray was so I can show you in these teaching sessions. Again, you'll find that on ultrasound much more easily, and also if there are any consequences of it. And here we actually have a horseshoe kidney. Doesn't project very well. It's also not especially visible on film, but we've also got bilateral kidney stones. And then chronic pancreatitis, which just gives us, you can see on here, try and highlight it, little bits of calcification, just transverse there, just crossing the midline. So classic for chronic pancreatitis. Nice stone there, just a pendicolith. Bladder stones, frequently confused with just calcified lymph. Yeah. Phlebolyths and all sorts of things that you find knocking around in the pelvis. So again, not a diagnostic. More chronic pancreatitis, rather more obvious this time, I hope. Yeah, calcification. So, got some adhesions here, giving a bit of trouble. The main problem, of course, is in the left flank there. All that metallic wiring is in a retained swab. Almost never happens these days. You're very rarely called out to try and localise anything. So that's it on abdomens. As I say, for those that missed the start, the real message is that they're mostly useless. I think there will come a time when they will go the way of a number of other nasal bones and other skull X-rays and other X-rays that are just completely useless. When I started out in the early 80s, was classic to do chest X-ray and erect and supine abdomen on almost everybody that came through ED with a bit of bellyache. There came a time when it was decided the erect abdomen was pointless, so we stopped doing them except in cases where it was query obstruction. So miraculously, every single patient then became a query obstruction. Clinicians do find it comforting to have them familiar, but what we really need to think is, how am I advancing the patient's diagnosis and treatment by doing this? And for abdominal X-rays, it's very rare. And so there's an interesting paper from 2009, Journal of Emergency Medicine, which just basically blew it out of the water. But for some reason, despite all our professions of doing evidence-based medicine, we have all the evidence that abdominal X-rays are mostly useless, and yet we persist. And it seems to be one of the hardest things to stop doing. Okay, any questions on that? No? I'll take that as a good sign, or you're all asleep. And so I have another. Look at some of the appendicular image. Some of these won't display so well because they're kind of designed for for proper projection rather than going through the slides as we are here, but we'll see how we get on. Okay. So it's really just the basics of interpreting X-rays. I will scoot through some of it because I think some of it is going to be far too basic for you, but this is the presentation I happen to have to hand, so we'll go through. Okay. We're looking at ABCS technique of alignment, bones, cartilage, soft tissues. Okay. I mean, what I'm saying here is always get, just moving that way, always get two projections because you're never sure that you're seeing the real thing. So that should be demonstrating the Prince William isn't making a rude sign to anybody. Big one.
I think you put it on presentation.
Okay.
Or no, just on the PowerPoint.
Let's have a look here.
Next button is the share again.
Yeah.
Share again.
Okay. Is that? Are we seeing that now?
Yes, we are.
Okay. Right. Yeah. So some of the basics of description. This will be. So we'll scoot through these because this is all very basics, but difference between proper alignment, subluxation, and dislocation. So we look at fingers here. This is just one thing that we still do get a number of requests. I think people, if it's a finger injury, let's X-ray the finger. Let's not X-ray the hand. Would be, I'd say, because with a hand X-ray, you won't always get the subtleties of dislocation of fingers. Can be quite difficult to pick up. Obviously, we also get satisfaction of search. But here, there's a nice fracture of the base of the thumb there, which was not readily apparent. So make sure you look at everything and don't give up once you've seen one fracture. Make sure you look at the rest of the image. Okay. It's one of the best ways that we make ourselves look rather stupid is by giving up when we see the nice obvious lesion and then turn down something else that's significant. So that now. Here, perhaps better demonstrated on the lateral. You don't always get a lateral on the hand, of course, because it relies on us seeing something, but obviously we've got nice carpometacarpal dislocation there. When evaluating the wrist, there's the apple in the teacup on a saucer approach for making sure we've got alignment of the radius, the lunate, the capitate. Okay, and any disruption to that alignment, which I'll have some examples of. So, but look at the age of your patient. We can usually tell if they're 4 to 10, usually an incomplete transverse fracture. 11 to 16 are the epiphyseal fractures. In fact, don't even bother looking for a scaphoid fracture earlier than 10 years old because you won't see it. It's barely calcified. But 17 to 40 scaphoid fractures, and then 40 plus, that's when you get your cos fractures, etc. Okay. So here we have green stick fractures and they're usually incomplete. You can see that the fracture line doesn't go across the whole width of the bone, but you do still get the distortion. And the Collis versus Smiths. Always a little cautious of naming fractures because they can mean different things to different people. Or the Collis and Smiths, I think, are common enough that not too many people are going to be confused. But certainly when I'm reporting, I would normally avoid calling it a Collis. I'll just say it's a dorsally displaced angulated transverse fracture of the wrist. Just going through some here. Here's the cup and saucer and apple thing. So the lunate and perilunate dislocations. So only visible on the lateral. So the normal alignment, we have the saucer of the radius, the cup of the lunate, and the apple, strangely shaped apple of the capitate. Okay. In a lunate dislocation, it is the lunate itself that comes invariably anterior. Okay. And often rotates as well. So we can see that the saucer is empty. Okay, and the cup is over here. A perilunate dislocation, the radius and lunate are still congruent, but everything else has dislocated. And again, that is usually dorsally. And then in particularly severe cases, I've never actually seen one, but it is possible in this end issues is that you get a complete mid-carpal dislocation with the lunate heading forwards and the capitate heading dorsally. Okay, so is that big enough for people to see? It's right, yeah. Okay, so excellent sign on the DP view, whatever you want to call it. The capitate becomes triangular. That's your big clue that something's going on. Okay, can we see pyramid shaped? Okay, and then on the lateral we can see very clearly that the capitate has moved anteriorly and the saucer is empty. Here's the perilunate dislocation. So the lunate is looking normal, but the capitate is clearly not within the articulation. So more named fractures, Gillespie fractures. So if we see, so normally these would spring out and impress you with the graphics, but I'll leave that. So we have a transverse fracture of the radius, but there is usually a dislocation of the distal radial ulnar joint as well, with the ulnar styloid going as well there. Scaphoid. Frequently missed on first presentation, so on our report we will always advise, or we always say if clinical suspicion persists, do another X-ray in 10 to 14 days. It seems to me that invariably you will do it anyway, so I don't know why we put the classically what we'd like to do, and if you want to apply for the funding, is get one of those MRI extremity scanners, get it installed, and then you can just MRI it on the spot, and that will tell you there and then. That's what they do in Glasgow, but that's because that's where Nigel Raby, who has the funding from his book, so he can afford one. So I think the official guidance is that MRI is the next step if you suspect scaphoid fracture. However, access to MRI is extremely difficult. And so in general, if you treat the symptoms and get the patient back if they need it. Okay. Not forgetting, of course, that the blood supply is from the distal pole, so so the danger of avascular necrosis is quite significant. Okay. Okay. You also want to look for the gap between the scaphoid and the lunate for a scaphoid-lunate association, ligamentous injury. The so-called Terry Thomas sign. I'm old enough to remember him as an actor. I think it's called the Letterman sign now because David Letterman has a similar gap between the front teeth. So that's mimicked by this space here. So if you see any widening of the scaphoid-lunate joints, then you have to assume there's ligamentous disruption to it, and there probably will be a fracture in there somewhere as well. But they are notoriously hard to find. Okay, if we come to elbows, it's all about alignment. The anterior fat pad is usually visible, but usually sits along the length of the humerus. The posterior fat pad in a normal elbow is never visible. So if you see a posterior fat pad, you've got an effusion. Now in adults, the effusion might be distant or chronic, but in children, the presence of the fat pads is you've got a fracture there somewhere, and you just have to behave accordingly. We've also got the anterior humeral line and the radiocapitellar lines, which help you with the alignment. And one. We've got an anterior dislocation of the radial head demonstrated there. On the lateral projection, the radiocapitellar line, if we take a line along the long axis of the radius, it misses the capitellum completely. And on a proper lateral, and this is one of the importance of getting proper projections done. The radiographers all know this and should be doing it. Again, with children, sometimes it's difficult and always possible. But I would advise, if you're not happy, if you're really suspicious of an injury, but we're not showing it, speak to the radiographers about whether they can do something else, maybe even get it better. Without accusing them of being rubbish. That's my job. And of course, complete dislocations, fairly obvious, and hopefully, even the loss of the anterior humeral line there is unnecessary to calculate. So the Monteggio fracture dislocation, so we've got proximal ulnar fracture and dislocation of the radial head anteriorly. So important not to miss those out. And when we come to shoulder and clavicle, the inferior border of the clavicle lines up with the inferior border of the acromion. So discrepancies in the superior alignment we're not worried about, they're fairly normal, but inferior alignment should be like that, otherwise you've got a subluxation or dislocation. So we've got normal AC joint there, everything is pretty well. There's also the subacromial space here, which should measure 1 centimetre. In chronic rotator cuff situations, you get reduction of that as the amount of ligamentous tissue in between reduces, and so the humerus is allowed to ride up. Here's a fairly clear on the right shoulder, but the left-hand side of the screen, we've got a very clear disruption of the acromioclavicular joint. If in doubt, the AC joints, one of the few cases where we'll have a look at the contralateral side, just for comparison. Okay. Okay, shoulders. Again, we've got the classic textbook presentations of dislocation. Unfortunately, patients rarely turn up in classic positions. And so they're quite interesting. So the old light bulb appearance of the posterior dislocation can easily be mimicked just by the patient holding their arm in an internal rotation. Looking a bit funny. So it's not always helpful, and we usually look for other clues. But again, it would be important to make sure we've got a second projection. The one we like here is the Garth view, which is with the patient still in the AP position, we just angle down 45 degrees. That is enough. The classic second projection of the elbow is the axial, where which is a direct sort of vertical projection through the joint. However, if the patient is able to maintain that position, they haven't hurt their shoulder, so we're inevitably compromising. So the Garth view is a 45-degree angle down on the ordinary shoulder projection. That is enough that if the glenohumeral joint remains congruent, then you can be confident that that is the case, that it is. However, any displacement, see on the left side, the humerus is displaced below the glenoid. That is an anterior dislocation. Okay. On the right, the humerus is displaced upwards, and with the angle, that means it's gone posteriorly. If anybody's interested in the geometry of that, then I can demonstrate later, but you don't need to know if you just remember the basics there. Okay, So how can you tell if your DP foot is a true DP and oblique? It's all about the alignment of the Lisfranc ligaments. So as long as everything lines up, you can be confident that you've got a true DP. Okay. So on the third annotated picture in the bottom right-hand corner there, we can see there's clear disruption that the second metatarsal border doesn't align properly with the cuneiform, and so we've got a Lisfranc disruption there. Okay. So some of this is very basic, so feel free to stop me if you want me to go back over any stuff, but I'll scoot through because I think I'm telling you a lot of stuff you already know. The classic for the base of fifth metatarsal, of course, is mistaking the normal apophysis for a fracture. So here we've got an example of both. The red arrow is the normal apophysis, okay, and the yellow arrow is the transverse fracture. So that's not to say the apophysis can't become detached, and you just have to kind of use your skill and judgment to work out whether that has happened here. But yeah, don't mistake that vertical line for a fracture. So number of ankle injuries, I will scoot through this because I'm guessing that you see ankle injuries every single day and are very familiar with them. True? Yeah. Okay. Obviously, the importance is the alignment of the ankle mortise, and in particular, these do occasionally get missed where there isn't an obvious fracture, but there is clear, and this is a very obvious one, obviously. This is a very clear widening of the medial joint space. So that indicates there's quite significant ligament disruption there. Okay. And the meson nerve, if you see an isolated either fracture or ligamentous disruption of the ankle, you have to suspect, because it's a ring structure, that it has gone somewhere else, and the only other place it can break if it hasn't gone at the ankle is up at the fibular head. Okay. A few soft tissue signs. Again, this is basics. I won't wait on these. The lipohemarthrosis, I'm hoping everybody is very familiar with. You get a fat fluid level in the suprapatellar bursa with an intra-articular fracture, and sometimes it's the only clue you get. So fat is dark grey and it floats on top of the blood, so you get a lovely horizontal meniscus, so you can see between the two. So you get, and there's kind of one scene never forgotten. They are obvious. If you're not sure if it's there or not, it probably isn't, and they're usually fairly obvious. So elbows, we'll just quickly go through the so-called sail sign. You will often see the anterior fat pad, but it should just sit flat to the anterior humerus. You only see the posterior fat pad in an effusion. So the usual thing there, and the important thing here, I'm going to have to just dismantle this a little bit, is understanding critol, which is the order of the ossification of the elbow. So capitellum, radial head, internal epicondyle, call it medial, but we needed a vowel. The trochlea, okay, the olecranon, and then the lateral epicondyle. So the important thing is that the internal epicondyle always appears before the trochlea. So I've got writing over this, which would normally not appear. But what we're seeing here is the internal epicondyle has become detached, and it goes into the joint space. So now that might be mistaken for a trochlear ossification center, but if you can see if you can see something that you think is the trochlea, but you can't see the medial epicondyle, then the medial epicondyle has gone somewhere, and invariably it becomes detached, flaps around loose on the end of its tendon, and disappears into the joint. Okay, so so other paediatric considerations, and paediatrics are probably the ones that bother us all the most, because kids are just difficult, aren't they? They don't ossify at the same rates. They've got weird bones and turn up not able to tell you why they can't walk. So we'll have a look at these. Trampoline fracture, very popular these days. It's a transverse compression fracture of the tibia. I hope we can just see that there, a little increased density traversing there. These are very subtle. There's also just a little bulge in the cortex there. These are very subtle, very annoying, but they are, just caused by trampolining. Often, if the kid is trampolining with a larger friend or sibling who's really sort of compressed stretch the trampoline as much as possible, and then the smaller kid comes down as that's rebounding up, and then they get quite a shock. So it's a compression injury. We also have the toddler fracture, which is a spiral fracture of the. See if I've got a better view of that. Doesn't look like it, does it? Can I make that bigger? So we're just seeing a very subtle lucency through there. So it's undisplaced. It's a spiral fracture, quite common in toddlers once they start moving. My particular area of interest, and we've got one going through the system at the moment, non-accidental injury. So the role of imaging is to provide some clues, but we cannot diagnose it's non-accidental. There are plenty of legitimate reasons why that injury might have been caused, but we can highlight the fact that it's unusual, and you guys, as the clinicians on the spot, need to decide, does the mechanism of injury and the age of the child match? Okay. If we've got more than one injury of different age going on, that's a concerning feature, of course. But as I say, imaging alone does not provide any proof at all. What we look at here is quite clear. I'm just clearly, I think, 1 month old. How does a 1 month old fracture their ankle? I might say they're non-ambulance. They're not doing anything much about up and lying there. So this is concerning, clearly. And if we look at another child, we had two children with almost identical injuries over the weekend, and this is kind of where the concern is that one was immediately put onto child protection system, the other one was sent home. But I come in Monday morning and I see two children of very similar age with almost identical injuries, and I was thinking, well, why did you decide one wasn't a safeguarding matter and one was? I still don't know that. I think it's just an error. We all make errors, but it's really just to highlight that we need to think about these. This is the classic sort of corner fracture of the humerus. Sometimes subtle. Again, I understand, but we've X-rayed the whole forearm, so we haven't seen the elbow very well. Okay, it's just a question of geometry that we're centering for that projection in the center of the forearm. So it's divergent rays that are imaging the elbow. If it's an elbow injury, we will center over the elbow itself, and it just improves our view of it. But I've magged up the AP there, and I hope, can we see just very subtly a little rim of calcification just laterally there. Yeah, and that's a corner epiphyseal fracture. Very common for if a kid is grabbed by the arm and yanked. There are good reasons why you might want to yank your kid if they're falling into a pit or whatever, so it's not an immediate call the police and get anyone arrested, but it does raise that concern, and so you need to just be aware of that when you're looking at the mechanism of injury. So that was an elbow where we looked at the forearm. The other child in the same weekend, we looked at the humerus instead. And again, was there any concern about the shoulder? Well, I don't know. But obviously, when you ask for the entire bone to be imaged, that's what you get. Again, the concern is that clearly the problem here is the elbow, and again, a supracondylar fracture. The story was maybe he's never witnessed, of course. It's the nature of them. Had the kid stuck his arm through the cot sides and then rolled, possibly. I can't tell you, not. I'm slightly more concerned. We've got a very obvious fracture of the distal fibula, okay, which I think is clear for everyone. There may well have been a very good explanation for that. What got missed initially, but fortunately was picked up later, is that there is a slightly older fracture of the proximal tibia. Okay, so this just should set alarm bells ringing. Really, why is this? You might think to fracture your leg once is unfortunate, but to do it twice when you're only a couple of months old, is rather more serious. And unfortunately, we discovered that they've got a similar fracture on the other leg when we came to do the survey. So it's the other leg there, and again it's the classic grab by the legs and fall up. So there we are, really. Bit of summary about stuff that you don't need to know because you're already doing it. But for paediatrics is probably the area that gives everybody the most concern, including us. We're worried about kids. We're worried about missing stuff. They're not great historians. Are we localizing the injury properly? And as I say, that can make a difference as to how well something's demonstrated on the image. Because if we look at the elbow, then we see the elbow. We're a bit more vague. I understand the reasons for it, but if we're a bit more vague and we look at the forearm, well, a certain amount of my attention is going to be distracted by the wrist. Are we seeing the elbow properly? Can we see? So don't worry about coming back if you don't think you've got what you need. Then come back to us and talk about it and see if we can do something else. Okay. With peds, I'm just myself. In fact, anything under 2 years old, we get two of us to look at it, just to make sure we've got a double report on it. Although not the rest of this week, because I'm the only one here. Okay. Has anybody got any questions about anything? I keep forgetting the people at home. We're all happy? Okay. Always happy to take queries if you know where my office is. We're very happy to